I welcome all the senior faculties and dignitaries and the other delegates who have joined for this webinar. This is the Public Awareness Committee AMOGS 2022-24, the first webinar. 17th of May is commemorated as World Hypertension Day, as high blood pressure is often called as the silent killer. 2 billion people globally, most of them are in the low and middle income class. We actually want to promote hypertension prevention, detection and control in order to reduce the morbidity and mortality associated with hypertension. I would like to thank Dr. Rajendra Singh Pardesi sir for giving us an opportunity to conduct the webinar under the AMOGS banner. Sir, I would also like to invite you as a chief guest for this webinar. Sir is currently the president AMOGS year 2022-24. He has been the past president, vice president of AMOGS and vice president of FOXI in the year 1920. He was the past chairperson of Food and Drug Committee FOXI in the year 2014 and was awarded the Best Answer Committee Award. Sir, I would like to you to please express your views on the same.
Thank you, Dr. Monica, for your kind introduction. So, respected Dr. Mandakini Meg Madam. Dr. Mandakini Meg Madam is so senior that I am feeling very awkward as a chief guest. So she is a grandmother of all and she is working in all the fields. And Dr. Sujata Dalvi, our active secretary of AMOGS, and our ever active energetic chairperson, Dr. Monica Ubardant. And I congratulate Dr. Monica and all the societies for conducting this nice webinar on the women's health. As hypertension is a main cause of maternal mortality, and now we are reducing mortality, and we just have to maintain below 70. Now our Maharashtra mortality rate is, I think, 38. I think we should step it down at single digit. So with these efforts, I think we should do it, and we will do it. These all other faculties, galaxy of faculties like Dr. Mandakini Meg Madam, she will be addressing us on prediction and prevention of PIH. Dr. Harshvardhan and will be addressing us prevention of hypertension and complications. And the chairpersons, Dr. Anjali Jama, Dr. Briya Kadam, Dr. Vaishali Datal, Dr. Shilpa Hambire, and all the organizing societies. I think this will be a great webinar on the hypertension as the eve of the Pre-Eclampsia Day, Hypertension Day tomorrow. So I wish every success to this webinar, and congratulations again to Solapur, Akluz, Pandharpur, Latura and Usmanabad Society, and to Monica Ubardhan for her future endeavor in AMOGS and in FOXI also. And I wish every success to our senior Dr. Meg Madam also for her future endeavor in FOXI. Thank you so much. Thank you.
Thank you, sir. I would now like to invite the Secretary AMOGS, Dr. Sujata Dalvi Madam. She is also the Joint Associate Editor of JOGI, and she is the Clinical Secretary of Mumbai Obstetric and Gynecological Society. She is a consultant obstetrician at various hospitals in Mumbai, and she is an honorary clinical associate at Navrojji Wadia Maternity. Ma'am, we welcome you, and we ask you to please give your address as a guest of honor for this webinar.
So thank you, Monica, for such kind introduction. In fact, I know Monica for more than 4 or 5 years, ever since she was the secretary of Solapur OBGYN Society. And since then, we have been interacting with each other for quite some time. And it's my proud privilege to be a guest of honor for today's webinar, which is on hypertensive disorders of pregnancy. It is one of the commonest non-communicative disorders of pregnancy, which leads to very high maternal mortality and morbidity. However, HDP is one disease in case if at all it is detected in time, or if we can always predict it, we can always carry out some treatment and thereby reduce the maternal mortality as well as morbidity. And we can always make a dream come true for our AMOGS president who wants to bring down the maternal mortality to a single digit. Monica Percy, as a convener of today's program, she is also a chairperson of Public Awareness Committee. She is very hardworking and very enthusiastic person, and she has aptly selected this topic for today. She has also selected various speakers, especially who are very experienced, like Dr. Mandakini Meg, who is going to speak on prediction and prevention of PIs, Dr. Harshavardhan Joshi. I'm sure both the speakers will do more than justice to the topic, and it will go a long way in reducing hypertensive disorders of pregnancy and thereby reducing maternal mortality as well as morbidity. All my best wishes to Dr. Monica and her team and for today's webinar. Thank you, Monica.
Yes. Thank you so much, ma'am, for your kind words. Your words and Pardesi sir's blessings will always be an inspiration to carry out further webinars. I now introduce the chairpersons for the first session, Dr. Anjali Jagma Madam. She is currently the president of Solapur OBGY Society, and she is the consultant at Jamma Hospital and Laparoscopic Center. She has held various positions in Solapur OBGY Society as secretary, treasurer, and organizing secretary for 2 consecutive zonal conferences. The second chairperson would be Dr. Priya Kadam. She is currently the president of Akluj, honorary secretary of Akluj OBGY Society for the years 18-19 and 21-22, and she is currently the president of Akluj OBGY Society. She is also the chairperson of Women's Wing IMA Akluj for the year 21-22, and she is the lead assessor for Lakshya Manyata Foxy Initiative. She has keen interest in laparoscopy and infertility. Priya ma'am, are you there?
Monica, can I just say thank you to Dr. Pardesi sir and
Yes, definitely, ma'am.
Can I say something?
Sure, ma'am. Sure, ma'am.
By the time, first of all, I'd like to thank AMOGS president, a very, very active and very, visionary president, I must say, because from the steps of the earlier AMOGS to the AMOGS where we are having now 20 committees, wherein the new committees form are so useful. So under his leadership and under the leadership of our Sujata as a secretary, I think AMOGS is going a great guns, and it is going to make a mark at the national level and as well as the international level, which is a vision of our Dr. Pardesi, and the forming the this guidelines committee, SOP committees, all these new committees are really a good vision. I really want to congratulate Dr. Pardesi, Dr. Sujata, and all the office bearer, and very enthusiastic team. Second thing, I must congratulate Monica and the Solapur Society. Yesterday, she has done a beautiful job of, out of the box, this WhatsApp thing. And we learned so many, Sujata, we learned so many new WhatsApp, and, to be used in our own gynec practice also, so many things we, as a doctor, we do not know. And I also spoke on the ICOG, which will again motivate, more and more FICOG people. If Sujata knows the Bombay people, I used to tell them, Priya Bora, there was only one wall between the MOGS and the Foxy office. That wall was never crossed till the time I became the ICOG chair and motivated. So it was again a very good thing for our AMOGS member that they are going to go get a higher fellowship and all these things. These are all very, very positive environment which has been created last year, before last year, and now this year is going great. So I think I would really want to thank Sujata and Pardesi and everybody for this wonderful, organization AMOGS, which you are taking it forward. So thank you. Now you can go.
Yes. Actually, all even committee chairpersons are so enthusiastic that the moment they've taken up the chairperson role, they've started having webinars every now and then.
Sujata, we are having with the commissioner and Sarna Tade, we are having.
Ma'am, enthusiasm is contagious from the seniors.
Join our NCD course from 2nd, 3rd, and 4th June.
2nd, 3rd, and 4th, ma'am. It is in the evening, 5 p.m. to 8 p.m.
Yeah, and all the government people are, there to, it is with the government of Maharashtra. Salam. Monica, please carry on.
Ma'am, yes, ma'am. Dr. Priya Kadam is stuck up with a cesarean section for fetal hypoxia. So I take the opportunity to introduce Dr. Mandakini Meg, ma'am. She was a chairperson ICOG Foxy from the year 2020 to 21. She has been the vice president of International Women's Association Central Asia, vice president of AMWI Central Council, national vice president Foxy from 2012 to 2013. She has been the past president of Indian Federation of Ultrasound and Fetal Medicine and Biology, the past dean of Indian College of Medical Ultrasound. She has also been the chairperson of Imaging Science Committee Foxy from January 2006 to 2009. She is the executive member of Mumbai Obstetrics and Gynecological Society since the last 25 years and member of FIGO Committee on Infections During Pregnancy. The list is endless, ma'am.
No,
He has been a faculty. He has been a faculty at various national and international conferences. Ma'am, over to you to present the topic for prediction and prevention of PIH.
Host is disabled the.
Yes, ma'am. Ma'am, we have made you the co-host right now. You can share the screen now. Shamendra, please make Dr. Mandakini ma'am as co-host.
No, still it is not done. No problem. It will be done. He's, I think. नहीं अजून नाही झालंय.
Yes, ma'am. 1 minute.
No problem.
Shamendra.
So my best wishes, Monica, keep on doing like this, and you are doing a great justice to the Public Awareness Committee. And I think you will make all the public aware of all the days and everything.
Ma'am, you can share your screen now.
Yeah. I'm just now I can share. So again, good evening to all the attendees, and again I want to thank Monica and Solapur Society for this wonderful. Am I seen? Is it seen, Monica?
Yes, ma'am. Yes, ma'am. Your screen is visible and your audio.
Yeah. So, given a topic of on this very World Hypertension Day, given a topic of prediction and prevention of preeclampsia, very, very important. Dr. Pardesi has already mentioned that Maharashtra has come to 38, and we want to really make it in the digit 1. But the major cause is, Sujata has mentioned that it is a preeclampsia, hypertension in pregnancy. Second is diabetes. Diabetes is again a very, very important cause. So we have to predict and the prevent preeclampsia. That will be our main goal in the pregnancy. So greeting from the AMOGS, and the Director General of this WHO has said that the preeclampsia, as per the WHO, that the preeclampsia is one of the leading causes of the maternal and perinatal morbidity as well as the mortality. 2 to 5% of the pregnant women are affected, and prevention and treatment to save lives and save even the amount and the GDP is also very, very important. And in South African countries, you can see that 8 to 12% of the some African countries are having very, very high preeclampsia. So no woman should die while bringing the life into the child. Bringing the child into this life. And among the top 3 causes, you can see here, hemorrhage, direct this thing, and hypertensive disorders in pregnancy are one of the major causes of the maternal mortality and maternal morbidity of the 10 to 15% of the maternal deaths. So this is very, very important. Now, preventing preeclampsia is a very big challenge. Why? Because in the early pregnancy, the ANC coverage is very less. Because patient come directly at the time of delivery or just in the 3rd month or 3rd trimester or very late. So globally around 5 lakhs newborn deaths are caused by the maternal preeclampsia each year as per the figure. So preventing preeclampsia will make all the difference. Suppose you come to know about the preeclampsia, hypertension in the early phases of the pregnancy. So we have to have the prioritize. What we have to prioritize is the push for the comprehensive universal health system approach, or as per the FIGO, that how we are going to do this. So we have to have a provider education to the ANC mothers, consistent adherence to the clinical guidelines. Time to time, there are so many guidelines are coming. WHO, AICD, all those guidelines are coming, and improvement in the referral pathway. So this should be our map for the prioritizing the prevention of preeclampsia, and the workforce shortages are there. We have to address this, shortages, availability of essential drugs. So many times when I was in Mantralaya, that time I used to come to know that small thing like methergine, like, Maxalp, they were not supplied. I used to tell madam, it is a very, our secretary, it is very cheap, but why you are not supplying? You are supplying thousands of bottles of normal saline and this, and but the drugs which are so important is not being supplied. So we have to address this and gaps in the governance in finance, as I have said. So prediction and prevention, the HDP, the hypertension during pregnancy occurs into 7 to 5% of pregnancy, 10 to 15% of death associated with this, and also monitoring and therapeutic then can be judiciously planned. So screening, like I have just spoken on the diabetic screening the earlier as a keynote address in the South, that time also screening of HDP has to be an important part of the regular antenatal care. So what are the potential crises? What happens when there is a preeclampsia or the hypertension in the early pregnancy? What are the complications? So you can see here cerebral hemorrhage, eclampsia, which will, if don't control the preeclampsia, then definitely it is going to go into the eclampsia, DIC. And then the HELP syndrome, AKI syndrome, hepatic failure, liver rupture, and the pulmonary edema, cortical blindness, placental abruption, and intrauterine death are the common complications and potential complications, crisis of the preeclampsia. So in preeclampsia is one of the leading causes of maternal perinatal death, and globally I have already told the figure, I'm not going to repeat, but it is associated with various complications, and most important again is intracranial hemorrhages. Then the life expectancy of the women who has developed the preterm or the preeclampsia requiring delivery less than 37 weeks reduced on the average by 10 years. Those, and it's a very startling this thing that the person who has, the woman who has developed prematurely, that life expectancy is going to reduce by 10. This is a very important factor. And women in the low resource country are very high rate of risk of developing preeclampsia. You can see in India also. We have not been covering the early population in the rural area where 80% of the population just go for the delivery. And government has taken out so many schemes, home delivery, 100% hospital delivery, and Janani Suraksha Yojana, all three antenatal cases. Our all Foxy member has done on the 9th day free checkup, and all these are, the idea behind that, the early diagnosis of all any disease which is in the ANC, for example, maybe it is hypertension, maybe it is diabetes, like that. So it is so important. Infant born to the mothers to preeclampsia are at a high risk of born prematurely, and delivery is only cure. So now the pregnancy-induced hypertension, as per the review of this journal, we can see here that hypertension developing after the 20 weeks of gestation will be coexisting in one of the following new conditions. What will be that condition? Either these are the revised guidelines, this thing definition of the preeclampsia 2014. Either she is having the proteinuria, or she is having multiple organ dysfunction, renal efficiency, creatinine more than 90, liver involvement. I have mentioned about the liver rupture. Then neurological complications, uteroplacental dysfunction, fetal growth restriction, very common. We do all the ultrasound and everything in such patients, and hypertensive disorders in pregnancy and maternal mortality. You can see here that the developed countries here in Africa, Asia, and see the Latin America now, and it is due to the hemorrhage and the hypertensive disorder. You can see here, the higher the this thing hypertensive disorder, higher is the mortality. So preeclampsia will complicate 3 to 9% of the pregnancy in the developed country, because the developing countries, because there is no intervention available at this stage. So now the maternal risk factor, major risk factors are pre-existing chronic hypertension. Suppose already she is having hypertension or other diseases, autoimmune diseases, then it will be a major risk factor. And minor will be, she is having advanced maternal age, nulliparous, short and long-term interpregnancy intervals, ART technology of pregnancy, obesity, ethnicity, family history, already of the pre-eclampsia and hypertension. So hypertensions in pregnancy, we have to find out whether it was a pre-existing or it is a gestational hypertension, or it is already, when patient we see it is already in pre-eclampsia, or there is a superimposed pre-eclampsia. So these are, while taking the history, while taking examination, you have to chart out differently. And what is the pathophysiology of this eclampsia? When the normal placentation occurs between 8 to 18 weeks, then cytotrophoblast invasion, spiral artery, low pressure and high. You can see here normal pressure is there. But as soon as the preeclampsia start developing, then that time you can see here immediately the less blood flow, spiral artery narrowing starts, and all the organs are affected. So because of that, it is a defective placentation, inadequate spiral artery, which I showed, remodeling, less dilatation, less vascularity, and atherosclerosis, and the endothelial accumulation of fat field and thrombosis. You can see very, very distinctly this is the pathophysiology of preeclampsia. Now the placental ischemia will lead to the endothelial damage. Again, the placental debris finally will lead to the endothelial damage, and inflammation. All this will lead to again the systemic inflammatory response syndrome and endothelial damage. And this, then after that, because of this microscopic changes, you will have multi-system changes occurring in preeclampsia. What are those changes? If you see in the brain, then the hemorrhage, vasospasm, edema, all these encephalopathy, these are the changes. Pulmonary edema, ARDS, complications of, then again in the liver, altered liver function test, and subcapsular hemorrhage, which I have mentioned already. For the fetus itself is IUGR, preterm labor, abruptio placenta. And here you can see in the heart, plasma volume, then the CVP will be low, contractibility, and again that. So this is a multi-organ. Once it starts, then it starts, giving all the pathophysiology changes in the all these multiple organs. So ideal predictive test should be how can we predict? So we have to predict by simple, non-invasive, rapid, inexpensive, easily reproducible, easy to perform early pregnancy and high sensitivity. These should be the test which should be available for the prediction. So diagnostic evaluation will be proper history is a clue to the many correct diagnosis. We think the history is not very important, but I must tell in each and every thing the history. Once you take a correct history and proper examination, which is a clinical examination, which is the key to the all the diagnosis, whether it is pre-eclampsia, whether it is diabetes, I tell you it is a very important, which is nowadays lacking in the clinical some new, the coming generation are lacking this thing particularly. So pregnant women in the HD should be asked for their obstetric history, specifically occurrence of the hypertension pre-eclampsia during the previous pregnancy, medical history to be obtained by the medical conditions, and also associated diseases like diabetes mellitus, hypertension, vascular diseases, nephropathy, and other such things. You elicit the history, whatever is possible from the woman or the relative. Then the careful and clinical evaluation at every visit. Suppose now first time you suspected, you sent her home, then again the patient will come. That time again you carefully see that and again evaluate the patient. During prenatal visit after 20 weeks of gestation, all pregnant women should be asked for specific symptoms. That is a very important. In Akola, we used to say around 150 to 200 people myself. So that time we used to see that visual disturbances, ask the patient about the history of visual disturbances, persistent headaches, sometimes they have headache, epigastric pain, increased edema, we have to ask the history and also examine the patient regarding it. Also, you take the now blood pressure. The blood pressure is very important. You should take, your expert person to take, or sometimes you also take to confirm. So mean arterial blood pressure more than 90, this thing, and prediction of HDP by MAP is the best when the measurements are taken both at the 11 and 13 and also 20 to 24 weeks. Then only one of these gestational ranges. So mean arterial pressure is a good predictor for the preeclampsia with the high specificity of 91 to 91.4%, and negative predictive value is 86.8. So the taking blood pressure is extremely important with the proper equipment and also proper, proper expertise, I must say. So ideal prerequisite for BP measurement is. So I think though it is very simple, but it is so important to tell everyone again that bladder should be empty. It should be quiet in environment, no tight clothing on the arm, no acute anxiety. Patient should stay silent, no caffeine and no nasal decongestant or ophthalmic thing be there. Then BP in the pregnant mother. So if it is more than say normal, less than 140/90, mild to moderate hypertension 140 to 159, and severe hypertension, of course, more than 160/110. So now how we do the, we predict is we can do the rollover test. So the rollover test can be done between the mid trimester and the first reading to be taken when the patient is on her side, and then ask her to roll on her back, and then second reading is taken. So first you take when the patient is on the side, and then ask her to roll over on her back, and second reading, the rise of blood pressure more than 20 is suggestive possibility of developing the SDP in future. The sensitivity of the rollover test in 20 weeks is around 43%, specificity is 81%. Now the second is Doppler ultrasound, isometric exercises, intravenous infusion, platelet calcium response, renin, and 24-hour ambulatory blood pressure monitoring also is very, very important. Now the fetoplacental unit dysfunction. So second test will be human chorionic gonadotropin, alpha fetoprotein. All these, tests can be done with the corticotropin and the pregnancy associated plasma protein A activin. So all these fetoplacental dysfunction, for identifying dysfunction, these tests are essential. And renal function, how we examine, we know that serum uric acid, then protein, then this hypoalbuminuria, hypocaluria, and also the microtransferrin. All this renal dysfunction can be diagnosed. So how should we proceed with this? So first we proceed with the clinical history. Then of course I said the clinical examination, very, very important. And your rollover test and whatever normal tests are there, laboratory test, and hemodynamic investigation, which I have already described. Clinical history, already I think age below 20, age above 20, nulliparous, history of HDP, multiple gestation, molar pregnancy, very important again. So all this, then existing diseases, obesity, autoimmune diseases, thrombophlebitis, protein C deficiencies, essential hypertension, already patient is having, some renal diseases, anemia, 80% of the Indian women are suffering from anemia. We are all aware of this. Connective tissue collagen disorders and psychological stress. So to continue with the history, how we risk assessment in the ANC is a family history. Then partner related factors is a limited sperm exposure. Then the new partner, male partner whose previous partner had the preeclampsia also is a very important factor, which we so many times we overlook. Pregnancy by ovum donation and the long interval between the two pregnancy is again a very important thing. Symptoms of preeclampsia, the spelling over, headache, vomiting, breathlessness, blurring of vision, epigastric pain, vomiting, persistent edema, all these things I think we all as a clinician are day in and day out are examining, but I'm just repeating. And the laboratory test we are doing this decrease, this is all PEPE, then second trimester unconjugated estriol, and all these higher tests can be done. And you can see the 6 major warning signs of preeclampsia has to be kept in mind all the time. What are those 6 is whenever patient says she is having headache, visual disturbances, epigastric pain, shortness of breath, spotting, and the pain in abdomen. So what we are going to do is a regular follow-up of the patient, plan for delivery, you have to plan whether she is severe preeclampsia, you have to deliver her first. Need for the transport, which she may be on a rural or primary health center, you have to plan for the, taking her to the higher center. Possible financial requirements may be there, and vigilance for any serious presentation. So these are all the signs which I have already described already. And timing of delivery is again very important. So 46% of mild gestational hypertension will progress to the pre-eclampsia to the severe disease. So this gestational hypertension can be taken to the term, while pre-eclampsia should be delivered at 37 weeks to avoid the consequences of progression of disease. So all this, the test is to be done regularly. Coagulation profile is also very important as a prothrombin time, INR, and this thing. So very, very important. Protein creatinine ratio is another very important, indicator. Suppose there is an abnormal protein creatinine ratio less than 30 milligram, significant of proteinuria in singleton pregnancy, or 40 milligram in multiple pregnancy, again is a sign, this warning sign. So renal function test, I think we are aware of all the renal function tests. Liver function test, elevated liver, we do all the liver function tests. Approximately 12% of the women with severe preeclampsia may have the develop the HELP syndrome. So these are bilirubin, routine this liver function test, and in the pregnant, and these are the normal values which are given. Now the angiogenic markers, circulating level of BGF or the serum concentration of PIGF are significantly lower, and also soluble endoglobulin has increased in HDP before the clinical manifestation. So superior performance ratio of this, superior performance diagnostic cutoff, and all these are very high test which may be available at a very advanced center. Then hemodynamic investigation is again very important. We all do the ultrasound, and this abnormal waveform in the uterine artery Doppler, such as increased mean PI, has been reported to be very good predictor of the early. This is, I think, one of the very, very important, because we tend to send all our patients to the radiologist or to the ultrasonographist and these fetal medicine expert. And this again will give a very good indication of the the prediction of the this preeclampsia. So role of also the Doppler plays a very important role in decision making, because once the report comes out, you have to make a decision also. So in presence of FGR, fetal growth restriction, Doppler plays a significant role in timing of the delivery and the neonatal outcome. And also medico-legally, I would like to say that you have to have all these reports ready, because the patient is going to question you. If it was so, why you have not delivered already, why you have not done this test, and so on and so forth. So I think we must do possible investigations which are at hand available to us. So first trimester, 36 weeks has sensitivity of 82%, second trimester 70 to 80%, and while the detection rate is 30 to 40%, age the false positive test are 5 to 7%. So I think these are all ultrasonography and color Doppler views, and it should be done whenever you want to do it, please do it, because to avoid the medical legal complication. So to protect the, so we have to predict and treat. If there is a mean arterial pressure is 160 by 100, cerebrovascular accident, eclampsia, we have to prevent and protect all these complications. Primary prevention will be by modification of the risk factor, like prevention of obesity, diabetes, anemia, renal disorders. All these are the primary preventions, and secondary preventions by diet, lifestyle modification. The role of aspirin is very, very important. And the low dose molecular and the no donors in progesterone is also again very important. A word or two about the HELP syndrome. So HELP syndrome, hemolysis is elevated, liver enzyme, low platelet count, very easy to understand. And again, the pathophysiology is given in detail. And most importantly, it occurs around 10% of the pregnant women. We have to keep in mind, approximately 70% of the cases develop prior to the delivery, and 10% of developing before the 27, and remaining cases occurring in the postpartum period within 48 hours. So very important is for the, these sources. So help alert, again, vomiting, patient can rapidly deteriorate. So we have to keep everything in mind. Aspirin is a very important drug, which is a 150 milligram at bedtime, starting from the late first trimester, reduces the risk of HDP by 17%. So it is again a very, very important drug. And you are preventing all the we have already mentioned about it. Heparin is also in high risk pregnancy, prophylactic low molecular dose heparin is beneficial in reducing the adverse pregnancy outcome when there is a concomitant therapy for the low dose aspirin. So this is again a very important paper. Now the tertiary prevention, we saw the primary prevention, secondary, the tertiary prevention is a judicious use of antihypertensive drugs and investigation occurring in the health, magnesium sulfate in all patients of severe. So now we come to the higher. And recently in the last 2-3 years, we have empowered the ANM of the rural hospital, primary health center to, we have trained them to give the Maxal to this patient before shifting the patient to the higher facilities. Future concept. Now the future concept is fetal fibrocytin and the free cell DNA in the women can help the prediction of HDP. Promising results are there, and metformin and the stents can be used as they act as the antioxidant, and animal studies have shown that the adequate human studies are still lacking. So these are the few of the future concept. So FOXY guidelines, prediction of preeclampsia, it is given in detail, is on the website. Universal screening is must. Assessment of clinical risk factor, careful history, and HDP, Dr. Gorakh Maipurkar has already, given this very detailed justices. I think we are going to have his guidelines and, SOPs also. So these are the research, these are taken from his this thing only. And prevention of preeclampsia, all women should be started aspirin 175 to 150, even earlier than the 12 week. And calcium also has to be started. So this is a management. We have to, if the the high blood pressure is above 160, you have to immediately start all the antihypertensive, and the goal should be to keep the mean blood pressure 140 by 90. Then only the fetal outcome will be. So be ready always with the magnesium sulfate and other drugs available in the labor room and other this thing. An indication for delivery. Now come to the last part. The indication for the delivery will be maternal, superimposed preeclampsia, severe hypertension, inability to control hypertension, and deteriorating renal, cardiac, lung function. Of course, is a indication for the immediate deliveries. And how to deliver is again a question. Suppose the induction of labor, absence of maternal fetal complication, induction. Then suppose there is a low Bishop score, then the induction of labor has a good success rate. Prolonged labor, then it should be avoided. And the cesarean section to be done in all obstetrical indication, low threshold to the CS to be followed. So take home message will be antenatal risk assessment of this prediction and prevention of eclampsia is very, very important. Then the 11 to 13 weeks during second trimester can help in the prediction of preterm preeclampsia. Initiative preventive measures such as low dose aspirin and increased calcium intake is going to help, and the other biomarkers which have potential to offer the major advances in diagnosis and management of HDP. So friends, the future pregnancy risk we have to calculate. And in conclusion, that preeclampsia is endothelial diseases. Women with hypertension, diabetes, etc. are at risk. Preeclampsia may exacerbate with the pre-existing endothelial dysfunction. Pre-pregnancy optimization is to be opportunity to intervene, and preeclampsia and maternal preplacental syndrome should be viewed as a risk factor for developing the cardiovascular morbidity and mortality. So friends, pregnancy is very special to us and make it very safe. It is in our hands. So let's save mothers from dying and prevent and predict the preeclampsia and save mothers. So thank you very much for your patient listening.
Thank you, ma'am. I request Dr. Priya Kadam, ma'am, please give the concluding remarks.
Good evening, everyone. Thank you, Dr. Mandakini Megh, ma'am, for a very well explained prediction and prevention of PIH. Basically, preeclampsia is an endothelial disease, and the importance of history taking, like family history and limited sperm exposure, that is a history of whether they were using condoms, then new partner, then importance of the mean arterial pressure, rollover test. Dopplers are important at the uterine Dopplers are important at 11 to 13 weeks, which can predict almost 82% of PIH in the first trimester. Then lab test like serum uric acid. Existing diseases history is very important, like diabetes, anemia, which leads to 80% of the PIH. Then PCOS and renal diseases. Then the six major warning signs for prediction of PIH, like headache, epigastric pain, decreased fetal movement, spotting, pain in abdomen, and blurred vision. Then she has already very well explained that we can prevent PIH by using aspirin 150 milligram at bedtime along with calcium, which decreases PIH by 17%. Then FOXY guidelines, which are HDP gestosis score. Thank you, ma'am. Thank you for a very nice lecture.
Thank you very much. Thank you, Chairperson, for almost duplicating my lecture. It's a credit to you, because by to the T for the percentage, each and every, I mean, you have done a great job of actually, repeating the lecture.
Summarizing the entire talk, ma'am.
Seriously, I'm very impressed, because generally what happens is chairmen do not look at the percentage and all those things. And everything, even the सीमेंट
अरे सुनो, जो मैंने स्लाइड वो करी है, फोटो खींचिए, इसको निकाल दो या फोटो कॉपी.
Samendra, can you please
अब मैं ऐसे कर रही हूँ, जो थोड़े आजकल लेक्चर हो रहे हैं, एक मतलब बाकी सब किताबें फेंक दूंगी.
Samendra, can you please mute
याद रखो, मेरे को याद नहीं रहता कि मेरे
क्या है.
Yes,
So
ma'am.
anyway,
Hello? Am I audible now?
yeah. So
Yeah,
those factors are very, very important, which I was saying, and those are little unknown factors, which we do not actually, in the clinical practice, we do not tend to, ask it. So I think, Chairperson, you have done a great job. Thank you very much, Monica.
Thank you, ma'am. Thank you, Dr. Priya Kadam, madam, and Anjali Jama, madam, for chairing this session. I now request the chairpersons for the next session is Dr. Vaishali Datar, madam. She is currently the president of Latur OBGY Society. She has been the director at Sarthak Hospital, Latur, since the last 15 years. And she has conducted various educational workshops and numerous defectomy camps at PHCs. The second chairperson is Dr. Rachna Jaju, ma'am. She is presently the secretary of Latur OBGY Society, and she's practicing at Latur in the last 10 years. She's an active member of PAC committee in the last year as well as in this year. And the third chairperson for the session is Dr. Shilpa Hambire. She is the secretary OBGY Osmanabad Society and an ex-treasurer of Osmanabad Society. She is practicing in Osmanabad since the last 12 years. Over to you, chairpersons, for conducting the next session, please. Rachna ma'am, Vaishali madam cannot speak because she is traveling. So can you please, Shilpa madam, Dr. Shilpa?
Yes, I'm there.
Can you please introduce the speaker?
Yes. Good evening, everyone. I take this opportunity to welcome and introduce our second speaker, Dr. Harshvardhan Joshi sir. Dr. Joshi sir is assistant professor at GMC Solapur. He is the owner of Joshi Clinic and Multi-Speciality Hospital and ICU, Director Critical Healthcare Services at Yashodhara Hospital, Solapur. He is consultant physician and ICU in charge at Yashodhara Super Speciality Hospital since 2009. He is physician and intensivist at Siddheshwar Multi-Speciality Hospital. He had successfully treated more than 5,000 ventilated patients and more than 7,000 ICU admissions. He was faculty for Mahakritikon 2019, which was held at Mumbai for workshop and lecture. Welcome, Dr. Joshi, sir.
Good evening. Good evening to you all. Thanks for giving me this opportunity to have a talk with you on hypertension. When Dr. Monica approached me, I was like a little skeptical actually. to give a talk on prevention of hypertension and complications. We are more in treatment part of it, but fine. I'll try my best to keep this session alive. Yeah. Hello, can you hear me?
Hello, sir. And we've made you the co-host. You'll be able to share your screen also.
Yes, yes. Okay. Yeah, can you see the screen now? Because I'm not very used to it. Hello?
Not yet.
Not yet?
Yeah. There's a green button at the end of the, in the middle of the tab, sir.
Just a second. Just a second. Yeah, there is a share content is available, but I couldn't just get it.
So there are 7 buttons at the end of the screen. There is one which is green in color.
Yeah. I got that button.
You can share the screen from the same, sir.
Yeah, share content. Share
So for
screen.
which you will have to first open your PPT on the tab, sir.
Yeah, that
Keep
I
your
did.
PPT open and then you share the screen, sir.
Yeah, I just got it. Yeah, screen broadcast.
Yes,
Yes.
sir. Yes.
Yeah, is it on now?
Yes, sir.
Yeah. Thanks, Dr. Monica. Just I will have a brief chat about the prevention of hypertension and its complications. Let us have a look. Prevalence or the problem statement, like a huge number of people all over the world between the age of 30 to 79 are suffering from hypertension, out of which 2/3 of them are in actually low to middle income countries. 46% or half of them are unaware that they have got hypertension. Less than half who are aware actually are diagnosed and treated. So effectively, only 20% hypertensives have their blood pressure under control. And because the penetration of treatment and diagnosis is so low, hypertension is still a major cause of premature deaths worldwide. So if you really look at it before the age of 50, if you look at the uncontrolled hypertension percentage of the patients, almost 62% people who have hypertension, they have not their blood pressure under control. Males, like almost 88% males and 50% females under the age of 50 are like not treated to the targets. As the age progresses, you can see the figure actually dwindling down, but still we got almost more than 50% of patients who are not controlled even with or without medical treatment. So morbidity and mortality due to hypertension, these global deaths attributed to systolic blood pressure were calculated actually from 1990 to 2016. This is the best statistics we could get. China and India are actually leading the number of deaths because of the high systolic pressure. So basically high systolic pressure means it really translates into high incidence of strokes and high incidence of acute coronary syndromes. So this is a WHO data basically, where region-wise number of deaths are plotted for the systolic blood pressure because of the high systolic blood pressure. If you look at it right from 1990s to 2016, the number of deaths are rising, so is the population. But if you roughly see, there is not much change. The science has progressed so fast and so many new medicines are added, but still right from 1990 to 2016, almost in the span of 30 years, like many deaths would have been prevented, but they were actually not prevented actually. So let us go to the risk factors for hypertension. Any family history, like any one of the parents or both parents having hypertension is a major risk factor. Then male gender and age. As the age progresses, incidence of hypertension increases. Like what you can keep in your control is diabetes, obesity, COPD, and your lifestyle choices, basically. So finally, all our talk of prevention will finally boil down to management of the treatment parts, which are variables which are under our control. Can't really help with the genetics. So let us have some look at the causal associations. Like the condition is present, causal association is like it has to be a cause and effect relation with the primary hypertension. High triglycerides, obesity, alcohol dependence, insomnia or low sleep, and low education are very clearly associated with the positive diagnosis of primary hypertension. Potential causal risk factors are diabetes, smoking, decreased sleep duration, and alcohol. So this is like a very general statement, but let us go to the evidence of it. Now, let us have a look at this chart of smoking and hypertension. This chart compares basically the people who are non-smokers to people who have stopped smoking and who are currently smoking with different levels of actually with the different intensities of smoking. They are categorized between past smokers, less than 20 cigarettes as 2 packs or more than 2 packs a day. If you really see the odds ratio or relative risk, despite the adjustment of age, BMI, and other multivariate factors, as the number of cigarettes per day keep on increasing, the risk of getting primary hypertension. We are not talking here about the cardiovascular death or CV risk. CV risk is very well established for smoking. But like if you are like smoking at least more than 20 cigarettes a day, definitely you are bound to get hypertension one way or the other sometime down the line in the next few years. Now, smoking is an established risk factor for cardiovascular disease, but it is also important positive predictive factor that has a causal association for hypertension. So this association was very well established for cardiovascular diseases, but now it has been clearly associated with the onset of new onset primary hypertension. Again, let us compare alcohol intake and hypertension, because I'm stressing the data on these points because these are the modifiable factors. So if we really count the number of units per day and the blood pressure increase, as the number of drinks per day goes up, the blood pressure goes up. Again, this can be a very clear-cut cause and effect relation when it comes to alcohol intake and hypertension. Alcohol intake or alcohol consumption and risk of hypertension, systemic review and meta-analysis, they like plotted different number of the studies and really came to a conclusion for males. If you really look at the top of the figure, anything more than 40 grams a day, means more than 3 packs a day, is clearly associated with diagnosis or it has a causal effect on primary hypertension. When it comes to females, it will be around 2 drinks a day that comes to the causal effect of hypertension. Next is obesity and hypertension. As we all are aware, like because of the increased body mass, increased BMI, fat stores, the heart has to pump. There is an increased peripheral resistance. So BMI and hypertension, if you can really look at the chart, look at the red parts on the graph, hypertension and obesity has a very clear-cut association. So now this is the standard. Yeah, this is a standard template for the for the JNC 7 guidelines for the stages of hypertension. Now, less than 120 or 80 was labeled as normal. Between 120 to 140 or up to 90 was pre-hypertension. From 140 to 160 or up to 100 diastolic was stage 1 and stage 2. Now, this is exactly not the case. The ACC guidelines have changed, but these are roughly the stages of hypertension what we got. Now, blood pressure classification referral guidelines. This is like from the typical ACC/AHA guidelines to prevent the complications of hypertension once you have established a clear-cut positive diagnosis. So if your patient is pre-hypertensive or he has elevated blood pressure, referral urgency is labeled as 1 year. There are two values given. Please have a look on them. One is the JNC and one is American College of Cardiology. Stage 1 and stage 2, like we have a referral duration of 1 to 2 months, and the critical high point, anything more than 180/110, should be referred immediately for treatment. Now, let us have a look on the complications of hypertension. We are all aware, actually, that the affected organs, first is a cardiovascular system, where we have a left ventricular hypertrophy. We have a coronary heart disease. In later stages, it progresses to myocardial infarction or angina pectoris, and hypertrophy gives a diastolic heart failure. For arteries, there is atherosclerosis. There is a distinct correlation with the aneurysms and aneurysmal bleeds. For the brain, it is a stroke, hypertensive encephalopathy. Again, cognitive decline and dementia are very important risk factor, like very important effects of hypertension, as we are seeing more and more patients coming in the geriatric age group. Retinopathy we all know of, and hypertensive nephropathy, and finally chronic kidney disease. So if we really look at the complications of hypertension, they start right from the stage 1. Initially, they are mild. For kidneys, they have proteinuria, biopsy shows nephrosclerosis. ECG or echo will give us a left ventricular hypertrophy, and retinopathy will be there. Okay. As the hypertension progresses to stage 2, finally this proteinuria nephrosclerosis progresses to coronary disease. Left ventricular hypertrophy gives basically a systolic or diastolic dysfunction. There is increased incidence of arrhythmias, very typically with the left ventricular hypertrophy. And this is over and above the risk of ischemic heart disease or coronary heart disease. Next, stage 2 hypertensives are usually at more risk of dementia than transient ischemic attack. The last, like stage 3 or anything that what we call as a critical point hypertension, they finally have an end-stage renal disease, myocardial infarction, basically congestive heart failure with or without preserved ejection fraction, and ventricular fibrillation or tachycardias. So then the issue comes up, can we actually prevent hypertension? There are a lot of interventions and studies from the US CDC that claim that yes, preventing primary hypertension is possible, but it claims immense effort to do so. So first thing what the CDC recommends is a DASH diet. That is basically dietary approaches to stop hypertension. The principles of this diet are typically low in sodium, low in saturated fats, rich in potassium, calcium, magnesium, fibers, and proteins. So let us have some brief view of DASH eating plan. So basically, there are some do's and don'ts. Initially, when I was doing my MD, that time the Mediterranean diet was very popular for the reducing the CV risk and reducing the incidence of hypertension. Now that space is occupied by this DASH diet plan. So basically rules like you have to have more whole grain vegetables, so whole grain cereals, then vegetables, fruits, moderate amount of the proteins, not the high ones, then avoiding saturated fats and increasing the intake of unsaturated fats, dairy product at least 2 to 3 times a day, and total intake of sodium what they recommend is 2.3 grams per day. That actually comes as a half a teaspoon, which is very rarely feasible. There is also a controversy of reducing the sodium intake below 6 milligrams per day, that people actually develop the salt craving, and so much low salt is again giving postural hypotensions. So basically benefits of DASH, reducing the systolic blood pressure by an average of 12 millimeter of mercury, and diastolic of 5 in patients who have hypertension. And in patients who have normal blood pressure, it reduces the systolic blood pressure by 4 and diastolic by 2, basically 4 by 2. So very mild benefit for a lot of effort, but still there is nothing more we can do to prevent hypertension. Again, next part is avoidance of the smoking or smoking cessation. Again, this is a very debated and controversial topic because many studies have shown some paradox. Let us go into that. This is the first study that is recommended by the WHO, basically the role of smoking cessation programs in lowering blood pressure, basically conducted in Taiwan. So what was the calculation? The people who have stopped smoking, basically their p-value actually improves and the incidence of hypertension improves. Then there was one large follow-up study by AHA, effects of smoking cessation on changes in blood pressure and incidence of hypertension, new onset hypertension. It was a 4-year follow-up study. They categorized this population in 3. First is a weight loser, then the population or size of the sample who maintained their weight, and size of the sample who gained their weight. If you really look at it, everybody who has stopped smoking, irrespective of if they lose weight, they maintain weight, or they gain weight, actually they show increase in blood pressure. It's the same way in males and females, that too. So this smoking paradox or cessation paradox was explained because the people stop smoking, probably they have increased calories, increased vascular resistance because of that. So, and the paradox is longer the cessation of smoking duration, like if somebody who has stopped smoking for 1 year and somebody who has stopped smoking for more than 3 years, longer the cessation of smoking, more is the blood pressure. This is a typical, very atypical data we got in this paper, and it was confirmed with various different papers as well. This is usually attributed to the weight gain after the stopping of the smoking. So it is very clear that smoking is a very high risk factor to get a newly diagnosed hypertension, but you may not get your blood pressure down if you stop smoking. This is a kind of the paradoxical message this study is given. Again, physical activity, 150 minutes of moderate intensity aerobic activities or 75 minutes of rigorous activities. It should be aided by muscle strengthening activities, either gym training, weight training, or strength training at least 2 times per week. So again, there is a class of patients who is called as a non-dippers on ambulatory blood pressure monitoring. A person who drops normally across the normal distribution, usually people drop around 10% of their arterial blood pressure during the circadian rhythm, that is during the night. These are referred as dippers, and one with a smaller decrease are referred as non-dippers. Non-dippers, they are proven to have a very high cardiovascular risk, but there is no evidence that non-dippers are they have a positive association with the diagnosis of primary hypertension. So if you are a patient is a non-dipper, he has a high risk of CV1, but not necessarily he will get a hypertension. Secondary prevention of hypertension comes to early diagnosis and early and adequate treatment. So preventing complications of hypertension, the way we saw, stopping alcohol actually helps to improve the blood pressure, but stopping smoking doesn't really get your blood pressure down. Same way, like control of blood pressure actually translates into prevention of complications like acute coronary syndrome, cerebrovascular accidents, and kidney failure. This is a very reverse cause and effect. It is proven well beyond doubt now. So let us have a look on the target blood pressure for different age groups and different situations. Uncomplicated hypertension, systolic blood pressure should be less than 40 and diastolic should be less than 90. For elderly, there is a discount of 10. You can accept a blood pressure of 150 by 90. For diabetes, target is 140 by 85, stroke 140 by 90. Only patients with CKD who have albuminuria, the target of blood pressure is very safe to prevent the progression of CKD, that is 130/80. So initially what JNC 7 used to tell us, and BP should be less than 120/80. It is not the case right now with the present evidence. With albuminuria is a stiffer target. Otherwise, safely across the spectrum, you can consider blood pressure of 140/90 as a normal, and for elderly, it is 150/90. Effect of blood pressure lowering, prevention of cardiovascular disease and death, systemic review. You really look at the relative risk of, they have compared the reduction of 10 millimeter of mercury in a systolic and diastolic blood pressure, very typically systolic blood pressure. If you look across all the studies and across all the parameters, including coronary artery disease, cardiovascular disease, stroke, heart failure, renal failure, any decrease of 10 millimeter of mercury in systolic blood pressure actually reduces the relative risk by almost relative risk to 0.5. So again, there are many agents to treat hypertension. Like conventionally, we are treating hypertension with diuretics as well as beta blockers, ARBs, ACE inhibitors. So this one study in particular, meta-analysis, compared the targeting of RAS, that is renin-angiotensin aldosterone system, and non-RAS drugs for the control of hypertension. These are the different trials basically. So HOPE trial, and basically if you look at the chart, anything that is targeting RAS, basically ACE inhibitors or ARBs, there is a significant reduction in CV deaths if drug is targeting renin-angiotensin aldosterone system than the drugs who are targeting the other parts. So definitely your ARBs and ACE inhibitors score better over and above our calcium channel blockers or beta blockers in reducing the cardiovascular death or coronary artery disease, diabetes and stroke. So finally, what we can actually get the message out of all this, hypertension is preventable. Diet like DASH diet and physical activity play active role in preventing hypertension, like preventing the onset of hypertension, primary hypertension. Cessation of alcohol is definitely useful. Cessation of smoking may help. Drugs working on RAS mechanism perform better in reducing overall cardiovascular risk and mortality than the non-RAS drugs. Thank you.
Hello,
Hello.
am I audible? Yeah.
Yeah,
Rachna ma'am,
yeah.
are you there?
Yeah, ma'am. That was an
Yes.
excellent presentation by Harshvardhan sir. And at the outset, I would like to thank all the respected office bearers of AMOGS and specifically Monica ma'am for conducting such a useful webinar on hypertension prevention and diagnosis part. So as we all are aware, sir has precisely said that 50% of the population is unaware of hypertension and only 21% are getting actual treatment. The line prevention is better than cure holds good here than in any other illnesses. So as precisely emphasized by sir, healthy diet, DASH diet, which has been elaborated, then lifestyle modifications such as quitting smoking, avoiding alcohol and regular physical activity is the key to success. And if at all the diagnosis of hypertension has been made, treatment should be started immediately. So I think that was an excellent presentation, and thank you for this opportunity. Thank you, ma'am.
Thank you, Dr. Rachna. I now invite Dr. Priya Bhinge. She is currently the Secretary of Pandharpur OBGYN Society. She has special interest in infertility and high-risk obstetrics. She is currently the chairperson of Mission Pink Health Pandharpur IMA Women's Wing. Ma'am, can you please give the vote of thanks?
Yeah. Am I audible?
Yes.
Yeah. Thank you, Dr. Monica, for kind words. I hope all had a very informative session. It is my honor here and privilege to give a vote of thanks to all the people who have contributed to this session to make it successful. At the outset, I first thank our chief guest of this webinar, Dr. Rajendra Singh Pardesi, who is the president of AMOGS. I also thank Dr. Sujata Dalvi ma'am, our guest of honor, and Secretary of AMOGS, for giving us the opportunity to conduct this program on this platform. I thank Dr. Mandakini Meg ma'am for such a wonderful lecture and accepting our invitation as a speaker. I thank Dr. Harshvardhan Joshi, physician from Solapur, for such an excellent deliberation. And also, I'll be thanking to all the societies who have affiliated to this webinar. President Solapur OBGY Society, Dr. Anjali Zamma ma'am, Secretary Dr. Archana Khare ma'am, Dr. Priya Kadam, President Aklus Society, Dr. Revti Rane, Secretary Aklus, Dr. Vaishali Dalal, President Latur, Dr. Rachna Jaju, Secretary Latur, Dr. Anuradha Garad, President Usmanabad, Dr. Shilpa Hambire, Secretary Usmanabad, Dr. P.V. Mohite sir, President Pandharpur. Lastly, श्रोतांशिवाय कुठलाही कार्यक्रम सक्सेसफुल होऊ शकत नाही. त्यासाठी I thank all our doctors attending this webinar, and we had a very good session, wonderful and informative session. I hope so. Everyone enjoyed it. Thank you so much.
I will request everybody to, take this thing video of, keep the video on so that we can take a nice photograph.
Yes, we can take a photograph of the same.
Yeah.
Everybody, please put your videos on.
So that, public awareness committee will become aware about the presence of everything.
Yes, ma'am. The theme for, actually, I wanted to just tell you that the theme from WHO Southeast Asia region this year is measure your blood pressure, control it, and live longer. The 4 priorities that have been highlighted in today's webinar would be reduce the modifiable risk, unhealthy diet, inadequate physical activity, and tobacco. If we focus on these 4, I'm sure we would be able to prevent most of the mortality and morbidity due to hypertension.
I want to add insomnia.
Yes, insomnia, sir. That is most common cause
for
for
all of you.
doctors. Yes. At least for gynecologists like us. Thank you so much, everybody.
Monica, photo.
Yes.
Photo card. कोणीतरी चांगला photo काढा. And at the end, I'd like to say something. All the present people, president, secretary, I am trying to go on the higher post, that is the president Foxy. With all your wishes, I could complete my tenure as ICOG Foxy chairperson very successfully and could give so many FICOGs, and you must have joined my certificate courses also in the past, and I want to take it further with all your blessings and the good wishes. I am contesting for the post of President Foxy, and I'm very sure that you are all going to support me and bring our own person to the national level. So thank you very much. Please.
Definitely, ma'am. Thank you for your guidance at each and every step,
and I
ma'am. Thank you so
very
much.
close to the all the societies who are in spite of so many difficulties are coming up and doing excellent work. I always motivate. So Monica and everybody knows here in Maharashtra, and trying to help everybody since last 40 years. Whenever I go to anybody's house, last time I think Rohini took me to her place. Madam, हे बघा तुमच्या हातचं MTP certificate आहे. So many people are doing so many things, and I'm very, very happy that in their life I could make some changes, help them, relieve around 14 this ultrasound machines. 17 were sold in the when Parag Patil was there alive. That time he took me to the Kalyan and I relieved the 14 because that time I was PCPNDT deputy director. So I could help all our members, and my endeavor is to continuously keep on helping So thank you very much, and please support me. I'm very sure that you are going to support me, but be very cautious while when the time comes. It is the next year, May, voting will be there.
Yes,
thank
ma'am,
you.
definitely.
Yes,
Ma'am,
ma'am.
best
Definitely,
wishes
ma'am.
are with you, ma'am.
All of us are with you, ma'am. Best wishes for the future ahead. Thank you so much, everyone, for joining the webinar. As this is the first webinar from the PSC committee, kindly excuse us if there are any fallacies. We are still in the learning phase. We expect cooperation from each and every society of Maharashtra to help us in public awareness activities. Any activities that you do, including anemia, school health programs, please do let us know for the same. Thank you so much.
Monica, one more suggestion is there. One more suggestion is there.
Yes, ma'am.
Because you are heading the Public Awareness Committee, and if you look at the Foxy Public Awareness Committee, they invite almost all the society. We are 43 societies. What my suggestion is, instead of 2 or 3 Pandharpur, suppose all the time you are taking our own people, nearby.
Ma'am, we have appealed to all the societies
No,
to
I'm
at
not
least
saying-
give us one coordinator, ma'am.
Correct. So what I'm saying, next time we do little more positively, involve Vidarbha, involve.
Yes, ma'am.
And
Definitely, ma'am.
those people are also wanting, like Buldana, I was a civil surgeon there. So they are, madam, आम्हाला बोलवलं नाही म्हणजे काय, तुम्हाला निमंत्रण नाही द्यायचं. But what I'm saying, let us make an effort and bring everybody when we are doing such a
Yes, definitely, ma'am.
and everybody will join. President, secretary, president, they want to join actually. So Buldana person told me, so many people told me, madam, तुम्ही एवढ्या चांगल्या activity करतायत, and it genuinely.
Right,
So we will be doing that.
Definitely next time we will involve everybody, ma'am. And I would also like to announce the 2 forthcoming activities. One is on the menstrual hygiene day, that is on the 28th of May. We will be organizing a chat show, which will be in Marathi, and we will be telecasting it on YouTube and Facebook for the awareness for general public. I would also request each member of AMOGS societies to plant 1 tree for the occasion of World Environment Day on the 5th of June. We will be sharing the flyer soon for the activity.
Hello, Monica ma'am.
Hello, Revati. Hi.
Hi, the conference just
pretty.
got over. It just got over, so I joined. If you
Yes,
have the link, I wanted to attend the lectures. So if you have the link recorded, please.
We are recording the entire session, and we will be creating a YouTube link for AMOGS PSC committee, and we will be sharing the link.
Yeah, I was looking forward to listen to the lectures, but I was already in the conference.
You are from which place?
She is the secretary of Faculty Society, ma'am, at present.
UIRT is going on very well, ma'am. Today the quiz and everything was very nice. PCO quiz was actually we were
Shetari, can
attending.
you stop recording the meeting so that this can go on unofficially?
Yeah. Quizzes are going on now. Yeah, very good.
Yeah, so it was nice. The participation is